Hi, I'm Jyoti Patel, the Director of Thoracic Oncology at Northwestern University Feinberg School of Medicine. The patient is a 73-year-old woman who presented with some cough and shortness of breath. She went to her physician and was found to have some dullness in her right lower lobe. She expressed that she had also had some weight loss and some dyspnea and exertion. At that juncture, a chest x-ray was done which showed a right lower lobe mass. A subsequent CT scan demonstrated that she had mediastinal adenopathy, a right lower lobe mass, and some areas in her liver that were suspicious for disease. She was otherwise pretty healthy. She had been working until a couple of years ago and was enjoying retirement. She was active with her family. She had a 50-pack-year smoking history and quit about 6 years ago. She was on some high blood pressure medicines, but had very few other comorbidities. At that juncture, she returned to her physician, and a decision was made that she should get a PET scan to look for other sites of disease. A PET scan confirmed that she had liver involvement. She ultimately underwent an IR biopsy, and that IR biopsy of her liver showed that she unfortunately had small cell lung cancer. At that juncture, her physician sent her to me as a medical oncologist for further opinion. She'd gotten an MRI of her brain at a previous appointment and then was coming back to clinic to talk about her treatment options. When we first met, we talked about her social structures in life. She was married, very involved with her daughter who was expecting a baby in the next several months. It was going to be her first grandchild, and she was thrilled about that. It was important for her to remain independent as long as she could, and to be able to see the birth of this grandchild. Given that she had disease in her liver, she was felt to have T3N3M1 disease. That's stage 4B disease. In small cell lung cancer, we often break down into two easier stages based on the VA staging system that's in greater accordance with treatment approach. And so she had extensive stage disease. Her performance status was intact. She had had some weight loss and some shortness of breath, so she was still PS1. Given her extensive involvement, we had a discussion about treatment options. At that juncture, we elected to do treatment with carboplatin and etoposide as a backbone and added therapy with durvalumab. She received the durvalumab with chemotherapy for 4 cycles. CT after 2 cycles demonstrated a significant response. She then had completed 4 cycles and was about to start maintenance durvalumab. She came to us to talk about how she was doing. She had had an improvement in her dyspnea and exertion. Her weight had increased pretty nicely. She was back to being active. She did have some fatigue after her chemotherapy cycles, but at the time of durvalumab, that fatigue had improved pretty significantly, and she was excited to begin durvalumab every 4 weeks with CT scans every 3 to 4 months, depending on how far she'd been. Our plan was to start durvalumab and to do a CT scan at 3 months and then at 6 months, unless she had new symptoms or unless she was found to have changes in her chemistries. We were able to treat her for 6 months with durvalumab. So this is a 73-year-old woman with a couple of comorbidities like high blood pressure who's found to have extensive stage small cell lung cancer. Our approach to extensive stage small cell lung cancer has changed dramatically in the relatively recent past. For years, the backbone of therapy for patients was carboplatin or cisplatin with etoposide, and the goal of therapy was to get tumor shrinkage early on and relief in symptoms. Generally, we treated patients for between 4 and 6 cycles. About 2/3 to 3/4 of patients had improvement in disease, but unfortunately, this was a cancer in which rapid relapse often happened. And depending on when that relapse happened, second-line therapies had varied benefit. So really, we've been using this backbone of treatment for decades with few improvements. The improvements that have occurred primarily, I think, are a result of better staging, so PET scans to perhaps find really limited stage disease and extensive stage disease, improvements in supportive care, and improvements in radiation.